So just a way to kind of give you an overview, if you look at a chemical or inflammatory category, you'll see that probably the best approach would be to look at their nutrition, supplements, different types of medication, of course, like Advil or the like. And modalities here are quite useful, clearly, in like the Bryce protocol or acupuncture, TENS, laser, all that kind of stuff. The mechanical category, which mostly we'll be discussing today, you got muscles, joints, nerve that are obviously involved. Of course, we have to evaluate whether they hurt more with load or without load, because that changes the approach a little bit. But this is where we kind of operate. Spinal manipulation, soft tissue work, ART, MRT, GRAS, and all that stuff. Functional exercises, Gary Gray, McKenzie end range loading, all of that kind of belongs to the mechanical category. Of course, you have the sensitization category, which is complicated to treat, kind of beyond the scope of this particular lecture, but most of us have been exposed to patients with this that belong in this category. As you may know, they're resistant to treatment that is typically of a mechanical nature. So this is where like you have to integrate psychotherapy, adrenal supplementation, acupuncture, cognitive behavioral therapy, biofeedback, and several others. So when you look at a patient that kind of presents themselves to you at the clinic or at the gym, we're always going to basically, if you want, follow these particular steps of care. A lot of times clinicians tend to go straight for either exercise directly or treatment directly, but they forget the most important thing to me, which is the sparing strategies. Like what is the habit that this patient has that is perpetuating the injury? Of course, in the case of chemical or trauma, you got to look for the inflammation. There's usually a very obvious acute form of trauma, but still, you got to have that discussion with the patient. Like, okay, you hurt your back doing, you're surfing, but still you have to still discuss, okay, what are the positions of sleeping, sitting, standing that are the least loaded to this patient? So back to sparing strategies, Professor Carl Levitt, who was Janda's partner, always said, of course, the first treatment is to teach the patient to avoid what harms them. Professor McGill said the same thing in some ways, but slightly different. Obviously, this either patient's not doing too much or they're doing too little. And that's where the clinician comes in, is like evaluate what is this patient doing too much of and what are they doing too little of, and balance that equation for them. And as we said, postural ergonomic advice is part of sparing strategies, very important. Do not underestimate it. So there was a couple of studies actually that were done on what do I start with mobility versus stability. This is basically where your job comes in, is like you have to evaluate who needs to be started on mobilization, who needs to be started on stabilization first. For example, in the case of inflammation, if the patient is fully inflamed, you're not going to go straight into stabilization. You might go to mobilization, clear the pain, and then go into stabilization later. If the patient has a nerve entrapment, same thing. You got to get rid of that nerve entrapment before you stabilize the area. Obviously, just some basic pictures off the website. SOAS releases, these are examples of them. Obviously, glute bridges. I like the glute bridges to be done with the bands around the knees, just for further facilitation. Some examples off the website also of adductor release. Glute medius type bridges is one leg kick, for example, and the side bridge on the bottom right picture is a great way to turn both the glute medius and the obliques on at the same time. So just to kind of give a little bit of a Janda review, there's the hip, we talked about a hip extension pattern here. Remember, the lower cross syndrome was one of his biggest things, is finding that pattern of psoas versus glutes, what's active, what's not active. Remember, that comes from sitting too much, essentially. Like we're sitting on your butt, obviously you're not going to activate your butt muscles, your psoas is going to get tight. So it's very important to me, like one of the other things that I do, in addition to making sure the patient is not sitting all the time, getting up, but I give him what, let's call it a micro break. So